Good afternoon, everyone. I'm Dr. Sarah Mustafa from DentistChannel.Online. Welcome to today's webinar about immediate implant in aesthetic area, how to achieve the best results. While we are waiting for the participants to join the session, I will introduce you to our company. DentistChannel.Online is a digital dental media company. It is your marketing solution for dental events, product launches, workshops, and courses. We also provide a collection of scientific articles and blogs about different topics in dentistry. We work hard to be your first-hand information on the technological advancements in the dental field. Now it's time to start the session about immediate implant in aesthetic area. If you have any question about this topic, please feel free to ask it in the question and answer box, and we will answer each and every question at the end of the session. I will start by introducing today's session speaker, Dr. Patricia Wood. Dr. Patricia is an implant dentistry specialist. She is a biotechnology doctor and the head of department in dental implants at the University Pacifico, Paraguay. Welcome, Dr. Patricia. It's our pleasure to have you with us.
Thank you so much, Sarah. Thank you to Dentist Channel for this opportunity. And thank you all of you, dear colleagues, to join this session today.
Thank you, Doctor. It's our pleasure having you on our platform. You can start the session, please.
Okay, now I will share my screen. So we can start talking about a very important topic that is immediate implant in aesthetic area. How to achieve the best results in this kind of treatment. As we know, nowadays, the patients, they are not looking for an implant or a crown. They are looking for a teeth or a tooth. They are asking us our best to achieve naturality. So we have tools to get best results. So now I'm going to talk about that, taking this article that I found very interesting that talks about immediate implants and the clinical guidelines for aesthetic outcomes. First thing we have to look when we are working in aesthetic area is the gingival biotype. This topic is very important because it's going to show us many information in advance. Second one is minimal trauma when we do a tooth extraction. Third one is presence of at least 3 socket walls. An ideal situation will be with 4 walls. Then the fourth is primary implant stability with engagement of 3 or 4 millimeter bone apical to root apex. This is very important because we know that immediate loading or immediate implant is very much related to stability of our implant. So this topic is also critical. Fifth, implant shoulder or platform should be placed 4 to 5 apical millimeter to anticipated gingival margin. When we work in aesthetic area with immediate implant, our bone won't be our reference anymore to place the shoulder or the platform of our implant, but it will be the gingival margin. 6, slight palatal lingual position of implant. Nowadays, we also know that we shouldn't place our implant close to the buccal bone. And then we will be talking about that subject. And 7th, fill the gap between implant and inner bone surface with graft material or autogenous bone with or without membrane. So those are the topics we have to look at when we are going to work in aesthetic area in immediate implants. And talking about periodontal biotype, look, we have to determine if this is a thick biotype, medium, or thin biotype. And you can see at the second line of images how we can determine this in an easier way. If we take a probe and we introduce that in the gingival margin, and we can't see the tip of this probe, then we can take that situation as thick biotype. We don't talk that much about medium biotype nowadays, but we can go to the thin. And if you see that image, you will see that it is so transparent, it is so thin that we can see the tip of our probe. And look, all the information that those kind of biotypes can give us. See, at the first situation, when it's a thick biotype, we can presume that we have bone around buccal of our root. The second situation, that is medium, we can see that maybe that margin of bone, of buccal bone, is little more apical. And when we have thin biotype, we can find some of those situations, like fenestrations of descents. So now in this situation, we know that we will have a level or a high level of complexity that we are leading with. So that's why this is the first topic, and it's very much important in our work in implants aesthetics area. Second point, minimally traumatic extraction. We cannot talk about a traumatic extraction because we are going to do some damage removing that tooth. So see, we have a lot of tools that we can use to remove that piece, like vertical extractor, forceps, we have curettes, and we have some manual tools to remove that vertically, to remove that piece vertically, not going to do a lot of damage in that procedure. Another point, very important one, is to talk about flapless procedures. If we can avoid doing a flap, making a flap, we can get best results. And you can see here that clinical studies has shown that bone remodeling is in immediate flapless implants will reduce horizontal and vertical bone loss and has the potential to maintain bony crest from adjacent sides. So if we can avoid doing a flap, then we will get best results in aesthetic. And here an example. Here we are removing that piece with a vertical device. See? But at that moment, we are going to remove one source of blood supply. And we have to remember that we have 3 sources of blood supply into the vestibular bone, which are those? The PDL, the ligament of that piece, the periosteum, and the bone marrow. And if we make a flap, if we perform a flap, we are removing one of them, that is to remove the periosteum. When we remove that tooth, we are removing one of those sources of blood supply, that is the PDL. So we only have the bone marrow. But if you think about anterior area, we can remember that in that area we have very thin quantity of bone. Sometimes it is 1 millimeter, sometimes it's 1.5, and in the best of the situations, it will be 2 millimeters. So we don't have bone marrow most of the time in this anterior area. So we are going to lose a lot of bone quantity. We have to know, to remember that when we remove that piece, we are going to lose height and width of our bone. Which tools can we use to remove less traumatically that piece that we have to remove? We can use the periotome, and we have to know how to use this and this situation. We can introduce the tip, mesial and distal. We can never work buccal or palatal. Remember that in this area, our bone is very much thin. So we can introduce that tip like this. I'm showing a video. I don't know if you can observe that video now. So we are cutting the PDL by introducing our tool. Never, never work buccal because our buccal bone is very thin and we don't want to lose it. Another tool that we can use is our forcep. So we can do two kinds of movements. We can do rotation movements and we can do vertical traction. We can never, or we should never, make buccal palatal movements, right? Because we know that this is very sensitive area and we want to maintain our buccal bone. So here, an example of how we can remove that tooth without much trauma. Yes? So now that we have our alveolus, we have to determine if we have or not presence of at least 3 socket walls. Ideal situation will be to preserve 4 of them, but most of the time we already lost because it was an infection or a fracture. But in another situation, maybe we can have the presence of the buccal bone. How can we know, how can we prove if we have that buccal bone? That is very important for us. We can use this probe that comes in our implant kit. So this is depth probe. So we can introduce that and we can try to feel if we have the presence very, very gently, if we have the presence of that very important buccal bone. Another important step is to clean that zone of that area very, very kindly with some curette. This is Marco curette. And you can see that it has a very sharp tip and is very small too. So we can clean that very easy. And this is another situation when we can observe the presence of our root and we can use a vertical manual tool to remove that. And this is also very simple to use. We can move that mesial distal, but never buccal and palatal because we want to preserve our buccal bone. So this is very easy tool to use. Sometimes it works, sometimes not, but we can have it in our practice. This is a serrated curette that we can also use to remove like cysts or a lot of fiber that we have, maybe we have in that place. And here I want to share with you a video of how this vertical extraction Right. Just. And fourth, something very critical too, we have to obtain primary implant stability. If we are going to work with a provisional crown, especially, we are depending of high primary implant stability. So that's very important. If we are going to wait some time to place a crown, we can work with low stability. But if not, if we are planning to place an immediate crown, we have to get at least 40 Newton centimeter to work with that provisional. And see, this is an hostile device to check how much stability we have in ESQ. But another tool that we all have in our implant kit is the torquemeter. So surgical torquemeter will show us how stable is our implant. And then we can decide if we are going to make a provisional, immediate provisional crown, or we can do some healing abutment, personalized healing abutment, if we have low implant stability. And this is a case I want to share with you. We had a vertical fracture of that 2.2 lateral piece. So here you can observe in the middle buccal of that root, we have a line. So that shows us that we have a vertical fracture, and we decided to remove that piece. But you can also see down the character of the bone at that area. And sometimes it becomes very difficult to decide if we are going to make immediate implant or not. After this image, we will see that we have 4 situations to work with, and we have to decide if we are going to make an immediate implant or not. In this situation, we have to position the implant very precise. We can't make any mistake. So those are challenging cases, but in this time we could do it. So see, in the last image below, you can see the placement of the implant really in a good position, talking about the character of that area. See? So we had luck. And then we are talking about primary stability of our implant. And we have to observe in our tomography that we have 3 to 4 millimeter apical bone to obtain that primary stability, because we are going to place the implant and make it stable only apical to our root that was removed. Otherwise, we cannot do that treatment. And this is very important to remember when we decide to place an immediate implant, right? So for 3 to 4 millimeter, it will be necessary to take this decision. And another point that we have to remember is that we cannot, or we should not work with immediate implants without tomography. This is very critical point, because now you will see that using that element, the tomography, is the only way to determine the sagittal position of our root in the bone. See, we have 4 scenarios. We have scenario type 1, type 2, type 3, and type 4. And look at type 4. We can hardly determine if we have buccal bone and palatal bone. And we have to remember that sometimes when our thick of bone is less than 1 millimeter, it will look like this, like we don't have any bone in front our root. So this is very important. So if we talk about presence of palatine bone and apical to root apex, we can observe this only with sagittal slides or our tomography. That's why it's so important to work with them. And here, sometimes we have type 1, so we can place our immediate implant easily, but then we have more complexity when we go to type 2, type 3, and the less desired situation will be type 4. But fortunately, we will have type 1 situation in 81% of the cases, right? And the less desired situation, that is type 4, we will find at 11%. That is not less. So we have to be aware of this situation. What if we have type 4 situation? Will you place the implant or not? What should we do? At this situation, we can go to preservation. Yes, we can do preservation of that area, of that bed, and then wait like 5 months to place the implant, because we have to create a place where to place our implant. And in type 4, it's not possible to do that, right? Now we have also an element that is guided surgery. So sometimes it will be making the position of our implant in hard situations easier. So now we are going to remove that fractured root with our vertical device. And now we have that piece out, removed, and we have the bed where we are going to place our device, our implant. So now, remembering what we were talking, we have to use that depth proof. Why we have to do that? Because we want to determine if we have the presence of the buccal bone. That's very critical, because now we are going to decide which biomaterial we are going to use in situation with or without buccal bone. So now we are going to touch the bone to determine if its presence it is or not. We also have to remember that we are going to place our implant palatally, because we want the emergence of the prosthetic screw in the best of the ways possible. That will be in the palatal side of our crown, right? So there we are going to determine if the gap, the portion free between our buccal wall and the vestibular part of our implant is enough or not. Ideally, we want a gap of 2 to 3 millimeters. So now I replaced the implant in a best position. So we got 3 millimeters gap to fill that. Fill it or not? That is the question too. In all of my cases, I do fill the gap, because we can have a collapse of our buccal wall. Filling the gap will stop the losing of that buccal wall. No, we are not going to stop that. It's going to happen anyway, but we can help to minimize the bad effects of the losing of that buccal wall. We are going to lose 2 millimeter height anyway, but with some biomaterials, we can at least have something in front of our implant. So if we talk about the depth of the shoulder of the platform of our implant, it will be placed 4 to 5 millimeter apical to the gingival margin. Sometimes our reference will be the bone, but when we are working without flap in anterior area, our reference will be the gingival margin. So we have to place our platform 4 to 5 millimeter depth. So this is Dr. Joseph Kahn, that he talks a lot about this subject. Another tip that I give to you today, I always work with soft tissue grafting, because it can also compensate the loss of bone that we are going to have anyway. So now I'm removing the epithelium, and I'm going to use only inner part of this soft tissue. I love to perform tunneling, so I'm going to partialize my soft tissue around the implant and going to place the soft tissue inside, so we can get best aesthetic result. This is not complicated. See, I'm just stabilizing my soft tissue at the place I desire to obtain more thickness of this soft tissue. See, just to catch that soft tissue grafting. And there you can see the set of implant. We have biomaterial and we have the soft tissue grafting all together already. As I got high primary stability, I can think about an immediate crown. So now with a provisional abutment, I can perform that. I'm going to make some wrists, some marks, because I'm going to use veneer made from acrylic crown, and I will only have to, I won't have a lot of stability, so that's why I'm doing some scratching in my provisional abutment. I can do that too inside of my veneer, and I'm going to use bonding. So I have to catch the provisional abutment with this veneer. And I love to use composite to do that. It's easier because we have to be fast. We are working in an area with a lot of bleeding, so we must be very fast. So now I'm going to capture it with light lead, and I got that. So now I have to clean it with sterilized water. Always we have to take care not to introduce a new microorganism inside our mouth when we are performing surgeries. So now cleaning it, and now I'm going to cover around my provisional abutment with composite as well. So now we got our provisional crown, and you can observe something here. If you look at the buccal part of our crown, you will see that I performed a concave surface. Why? Because we don't want to push our soft tissue. If we do some convex surface, we are going to push our soft tissue, and it is going to go apical, and we want that. We will not like to have that in this first period. So we have to do this always. And here you will see a provisional with a lot of marks showing you how to perform that inner part, the part that will be contacting with the soft tissue. So here we have our provisional, and you will observe that this crown is shorted related to the other side. Why? Because we want less touching possible. So we have to talk with the patient before in advance, telling that patient that the crown won't look that marvelous. It will be shorter. Why? Because we don't want much contact Yes, and patient must be aware when we are doing this immediate loading. This is immediate non-functional loading. Why? Because we are trying to avoid the contacts. So we have to aware the patient that the patient must take a soft diet in 2 months. So this is the part of our patient. And see, we have to look at the movements. So we have to check if the crown is touching the antagonist or not. That's very important because we should remember that implant can't move 0.1 millimeter. That's all our implant can move. If we don't get that, if the implant moves more than 0.1 millimeter, we will have fibrosis. We won't have osseointegration, right? Now we are going to talk about that provisional crown. I like this article that talks about contour management of implant restorations for optimal emergent profiles. This is also a guideline for immediate and delayed provisional restorations. What do we want when we place an immediate implant at anterior area and we think of performing an immediate crown? What we want is to maintain the natural form of that area. Because if we do that, we will get really high aesthetic results. So here, which are the objectives of temporary restorations in immediate implants? We want to maintain existing soft tissue architecture. We have to avoid soft tissue compression. That's why we were talking to perform a concave surface where our crown is touching the soft tissues. We want to allow space for regenerative process. We want to allow stable clot formation alone or in combination with soft tissue graft and or bone substitutes. Upon maturation, it will become bone or soft tissue. That's why we have to respect that area, performing our provisional concave. So, subcritical area has a concave. I will talk now about the areas, but remember that subcritical area has concave as possible to leave space for the coagulant and graft material to stabilize. We don't have to compress those. Smooth and polished surface will help to create a smooth transition, minimizing contamination during the cure. And now, this is very illustrative image. You can see the provisional crown, the implant, those white spots are biomaterial, and then we see the bone bed and we see the soft tissue around, and also you will see a small soft tissue grafting. In that space we have to respect. So now that blue line will be our critical contour. And what's critical contour? Is the most superficial area and will influence the gingival level and zenith location. And what was zenith, by the way? Zenith is the most apical point of the gingival margin scallop. And it's very important to preserve that for aesthetic. So we can make an incision where our zenith is located, because we are going to have a scar and it won't be great to have that in anterior area. So in this image, we have to draw with a sterilized pencil that line that will be our critical contour, just following under our gingival margin. Next, we are going to paint, to mark our subcritical contour. It is located 1 to 1.5 millimeter under our critical contour. So this line will be under our margin. And it corresponds to the deepest zone and influences the peri-implant soft tissue support and gum color. So we have to do those draws in our provisional crown because we are going to work on it. Below that subcritical contour, we will have the subcritical area. And there is where I'm going to work. There is where I'm going to remove material or to place material. There is where I'm going to make it concave or not, right? And then that green draw is our regeneration space, where we are not going to make pressure. Why? Because we have the presence of the soft tissue grafting or the biomaterial. So here we have our provisional crown with the characters we desire at the beginning. So you see that the surface, the subcritical area, remember, subcritical area is concave. At the beginning, we always have to do that. We always have to get that concavity in the buccal part of our provisional, right? The critical contour that is immediately under our marginal gingiva, it will stay like that. It doesn't matter. We don't have to remove any composite from there. And that's the aspect of immediate provisional. The lower marginal one is our immediate provisional. And what we want now, we want to push the marginal gingiva apical. How to do that? Am I going to cut that? No, please don't. Because see the aspect of that gingiva around the crown. See, the keratinized gingiva looks very natural. So we have to put some more composite in that concave area to work with the provisional. If we make convex aspect in that area, we are going to push apically our margin. That's the way to work in this situation. Never cut the gingiva. Always work with provisional. So we want to move it apically. So look, just by working in that subcritical area with more composite convex aspect, we get that result. So now what we have to do is work only in the zenith to make this look nicer, right? Look, now we got a nice provisional. This is still a provisional that I made with composite. So this is the aspect we are going to work, but later, when we had also integrated implant. And then we can lift our crown like this, straight, to maintain the position. How do we work there? How to make it convex? Just with composite. So now that we got the desired result, we can leave our subcritical area straight to maintain. This is a clinical case, very challenging one. See, the dark crown, it's apically with its margin, so it's a very challenging case. What we planned to do here, it was a fractured root. So we planned to remove only the fractured buccal part of the root. We let the other part there. Why? Because we want to have more cloth, right? We want to have more cloth to have primary closure in the future. So one part of the root is inside, the mobile part is taken away, and now I am working with soft tissue, okay? Because we have to avoid moving this keratinized area to close our where the piece was. We have to avoid that, because if we do that, we are not going to obtain good aspect in the future around our crown. See, then we close that with soft tissue, and we did a provisional to stay there for a long time. Now I have soft tissue all around where our root is, and now I can work better. In this case, I had to perform an open flap. Why? Because tomography showed me that I had not buccal bone, so I have to regenerate it. When I can avoid doing this open flap, when I have my buccal bone, okay? So now I will place my implant, and you will see I did that palately, and now I'm going to cover that place with grafting and a membrane. See, this is the way I have to start the preparing of my bed. See, and then I can move my tools in a vertical position. Is this, sorry, is this the best position of the implant? Or this last? Which one you think is best? Position it very buccal, close to the buccal bone, far from the buccal bone, or in the middle. We know that this situation, very close to the buccal bone, is worse. Going to place my implant like this is best, because I'm going to stay away. I won't pressure that thin buccal wall, and I'm going to have that gap to fill that with some material. And the third one is also not good. We are very close to buccal bone, and we won't have place to put our biomaterial. See, what do we observe here? Our implant is in the right position. The prosthetical screw will be emerging in the cingulum of my anterior crown. And you can see in front a membrane, right? So it is a membrane that stays for 45 days. And I'm going to use also some grafting material. So now I'm closing that area, and I'm going to wait 6 months to start working. And now how it was, I was not so happy with the buccal aspect of the soft tissue. So I did more grafting, more soft tissue grafting to obtain more thickness. And then you have there the abutment for a crown, for a screw crown. I love to work with screw crown. So we have this situation. Look, it was before, and I got this with provisional. It's not ready yet. But now we have the final result that is okay. We are happy with this, patient is happy, and you can observe that we preserve papilla. That is very, very hard to preserve, but in this case, we were lucky. So this is final result of this case. It was the initial tomography. See, I will show to you with this red circle. We had not vestibular or buccal wall. So in this second circle, you see presence of biomaterial and also presence of new bone formation. Okay. And here an illustration showing that we are removing that root with a forcep very gently, and we are going to place our implant buccally positioned, right? And here, the correct position and grafting that gap. Sometimes we cannot position our implant in the best way possible. Why? Because we saw that we have 4 different types of sagittal position of the root. So we are depending of those situations. But this is very important. We always have to fill the gap that is between the buccal bone and the frontal part of our implant. It is very important. And we can do that with bovine, we can do that with artificial bone, we can do that with the bone of the patient, but we have to remember that they are viable particles, and the size must be 1 millimeter till 2 millimeter. If our particle is less than that, we won't have viability in those particles, right? So now positioning the provisional abutment, and we are going to cover it with a dam, and we are going to perform a personalized healing abutment. It is just a cutted crown. When we are going to opt for that, when we have low stability of our implant, so we are not going to take any chance to lose our osseointegration. So I can perform that with composite. So look, there is our implant, very well positioned. It is 4 to 5 millimeter depth if we are taking count of our marginal gingiva. See, you can measure that with a probe, a periodontal probe. This is also very important. We have a part of our abutments that we call transmucosal. And we have like a chamfer here in all our abutments. And this chamfer must not go very deep, because we don't desire to put the transition of that margin with the crown near to the bone. So this is very important to select our abutments. So here, the provisional abutment, yes. And now I'm going to work outside the mouth of the patient. I had a model before surgery to make those steps easier, see? So with composite, I can make a shell of that part that I desire with that triangular format, and I can get the shell till the last moment when I'm going to catch the shell with my provisional abutment. And now again, working outside the mouth of the patient with composite, cutting the provisional abutment and working like this, see, to make it concave. At the beginning, we always have to leave that concave. So now we have our personalized healing abutment. Place it into the implant. And look, what a beautiful view we got working like that. So this is very natural. See the amount of soft tissue. See the emergence profile of this provisional. This is what we want, because we are going to obtain a lot of naturality in our restoration. And this is the last case, using again that vertical device to remove the piece. This is a canine, very huge root. And now placing an implant that is made for immediate implant. This implant has the character to obtain easy primary stability, because we have a lot of macro geometry, and some of those are helping us to obtain the primary stability that we desire in immediate implant. So see, this is location of our immediate implant. We are measuring the depth of this implant that we know that we have to lift the platform 4 to 5 millimeter deep, taking care of the gingival margin. Now we have this situation with the soft tissue grafting positioned, and now we place it also the bone grafting material. Okay, and this is something new in the system I work, that is Syn dental implants. This is a peak healing abutment, and it's so easy to work because we can cut this, we can make the form we want, so it is very easy to work. So we have like a personalized healing abutment without working so much, like we saw using the provisional abutment and composite. So this is the situation after 2 weeks. It is very friendly with the soft tissue, this PEEK material. So this is situation 2 weeks after surgery, and you will see that I placed a bridge sustained of using the old implant, so the patient won't stay without that piece. And this video I want to share with you is to show how do we have to perform the bed of our immediate implant. So please let me know if you can see the video. See, we are taking a point in the palatal wall, and we go like that because palatal wall is very hard, so we have to go that position, and then we straight our drill. So now we are making the right position of our preparation. Also important, anterior implant can be more than 4.5 millimeter diameter. Only that. As thinner, as better. I love to do the capture of implant with my motor because I verify if I change the program. Now going deeper and measuring the depth of implant platform to the marginal contour. I always have to use the cover screw before filling the gap. This is synthetic material, hydroxyapatite. I love to work filling the gap with this hydroxyapatite, and this is very important. Prosthetic reverse planning, thinking about the crown before going to perform our surgery, right? So this is what I had for you today. This is what I wanted to share with you today, and I'm going to talk about some conclusions. Immediate implant placement. We have two alternatives to maintain the natural emergence profile. With a temporary crown, if we have high primary stability, or customized healing abutment if we not. Okay, so this is what I wanted to share with you today. I'm so grateful with DentistChannel.Online. You can find a lot of videos in my YouTube channel, Patricia Fretes Wood. So please join that. Please add me in Instagram and we can share experiences. So Thank you so much, Sarah. Thank you so much, colleagues present today. And thank you so much, Dentist Channel Online.
Thank you so much, Dr. Patricia, for sharing your knowledge and your experience with us. So meanwhile, I'll ask your permission to introduce our company to all the participants, and I request all the participants to kindly put their questions in the question and answer box. This is our organization, Dentist Channel Online, Healthy Smiles, Wealthy Lives. Dentist Channel Online is India's first digital dental media company. We did webinars and courses with more than 400 national and international speakers, many successful world implant expos, online workshops, and live dental webinars. If you're not a Prime member yet, kindly join our family to get free certificate of participation after every event and get exclusive offers and discounts on our on-site and online paid workshops and courses. Most importantly, Prime members will be awarded with 1 CPD CE point for each free webinar. So you can join our Prime membership and use my code SAR100 in order to benefit from a discount. So you'll be paying around $10 per year. This is an example of the certificate of participation that you will get after every event. About our upcoming webinars, we have tonight a webinar with Dr. Mahmoud Ramadan about patient complaints in removable prosthodontics, how to diagnose and manage. We have another webinars, one with Dr. Mahmoud Salama happening on May 21 about easy techniques for shaping and clinical tips before obturation, and another one on May 22 with Dr. Majiha. She's going to talk about dental marketing, the ongoing social media trend. I request all the participants to kindly save this number and then send a message on WhatsApp with their name, so they will be added to our broadcast list and they will receive everything about our upcoming dental webinars and courses. Today's webinar is sponsored by NovaMind. NovaMind offers a full spectrum of implants and prosthetic solutions that accommodate any clinical need in modern implantology. We successfully supply highly demanded dental implants types called internal hex, tissue level, bone level, and active conical connection. Our EU production unit and product quality is appreciated worldwide. If you want to know more about NovaMind, kindly check their website. And last but not least, don't forget to follow us on our social media platforms, Facebook, Instagram, and YouTube. Okay, so now we can move on to the question and answer session, but I don't see any question. I only see very good feedbacks about this nice presentation. It was very clear, very informative.
I think someone asked about the filling material.
Yes. Where is the question? I can't find it. If you have it,
yeah,
okay.
we can opt for many kind. We can use the bone of the patient with particles 1 millimeter till 2 millimeter size, and also we can use synthetic material like hydroxyapatite. I believe you don't use animal products, right? We also have the option of bovine, but you can opt for artificial synthetic material like hydroxyapatite.
Okay, I think that's it. We don't have any other question. Yes, we have very good feedbacks about this presentation. I would like to thank you again, Dr. Patricia, for sharing your knowledge and your experience with us. It was a pleasure having you, and we are looking forward to organizing more webinars with you in the future.
Thank you so much to all of you. Until the next time.
Until next time, inshallah. Thank you, everyone, for joining us tonight. Have a good night.
Thanks. Bye-bye.
Bye-bye.